Hello, good afternoon. Thank you for your words, Mr. Chairman. This is an interesting topic. Actually, it gave me great pleasure to prepare this talk. Because when we do prostate surgery, there are mandatory indications, and for those it's very simple for us to decide the surgery. If the patient has refractory urinary retention, if the patient has impairment of the renal function with hydronephrosis, persistent urinary tract infections, stones or large diverticuli, or persistent hematuria, I'm sure that the indication of surgery is simple. But unfortunately, we do surgery in the majority of cases because of the persistence of bothersome LUTs. And here is an area where the interpretation of the symptoms from the surgeon might be very difficult. And in fact, it might be extremely important to discuss very well with the patient how bothersome are the symptoms. Because then we will have to choose one of these surgeries. And in green, from left, less invasive to more invasive, you have those that received from EU guidelines a strong indication. Urolift, TURP and the variations, the vaporization, the incision of the prostate, or the open prostatectomy and the laser variation, the HOLEP. Then in red, you have the surgery, the techniques that are available, but that still receive a weak indication for being performed from EU guidelines: aquablation, prostate embolization, and the Rhizome system. And the others that are in purple, well, they are completely out nowadays. So TURP is the gold standard. And if we look to this meta-analysis, and if we show this meta-analysis to a patient, what the patient will expect is that at the end of surgery, he will be perfect and without symptoms and void perfectly. The Qmax is expected to increase almost twice, good reduction in IPSS, no post-void residual, excellent improvement in quality of life, and a durable effect of TURP. Well, LUTs in men are complicated. These are data from the EpiLUTs, and in men above the age of 40, 70% have symptoms, and voiding symptoms are not the predominant. In most cases, what we have is a mixture of voiding and storage symptoms, and eventually post-micturition symptoms. And here we have immediately a problem, because not all these symptoms will respond in the same way to TURP. And in this Japanese study, this is quite clear. If you see the rate of response after TURP, well, the yellow bars indicate the voiding symptoms. They respond well. Not totally, but they respond relatively well. But those that are in green, particularly nocturia in dark green, you can see that the persistence will be very high because the rate of response, the rate of improvement is much lower than we could expect. Also, we have to understand that with age, patients might suffer from other problems in the bladder, and one is the Cruz'un underactivity we spoke about yesterday. And in this study from Bristol, and I believe that Professor Paul Abrams is able to do excellent TURPs, but after 10 years, the patients with symptoms, well, the majority of patients with de novo symptoms, in fact, they have the Cruz'un underactivity, not a new obstruction, showing that he was, in fact, able to do an excellent TURP. Then we also have to understand that we are probably everywhere in the world. These are data from Montreal, but probably it's true everywhere in the world. We are treating older patients. And older patients have larger prostates. And larger prostates may be related with lower Qmax, higher IPSS, larger post-void residuals. And why? Because we stretch the use of medical treatment. We prolong medical treatment. And eventually, we are going to treat our patients at too late stages. And so it is not a surprise that in France, and these are in the horizontal line months after TURP, or the French guys, the French men start, despite the surgery, to resume the medical treatment. Plant extracts, 5-RIs, alpha blockers, combination, antimuscarinics, and some of them very quickly after the surgery. And at 1 year after the surgery, 10% of the Frenchmen are already in medical treatment despite TURP. It's really worrisome. But this is not in France only. In Canada, if you look into Canada, the situation is exactly the same. After the surgery, many patients will start alpha blockers, 5-RIs, or a combination of anticholinergics or beta-3 agonists. So the symptoms do not disappear completely. The other point that is less discussed with the patient, and the patient might be unhappy if that is not discussed in advance, is, for example, the time of hospital stay. It's very common to say, oh, TURP is 2 days in the hospital, no more than that. It might be ambulatory. But in fact, in France, the median hospital stay is 6 to 7 days. It's rarely discussed with the patient the possibility of retention immediately after surgery and the necessity of the revision of TURP while in the hospital, and that in total might be almost 7%. And of course, we need to discuss with the patient the risk of ejaculatory function. The patients will lose ejaculation. Well, this is a rare event. And then is the issue of a second prostatectomy, a second TURP. And I still remember when I saw for the first time, I was still a resident, when I saw this data from Dr. Ross in New England Journal of Medicine, when TURP had a rate of retreatment at 8 years between 12 to 15% in Europe and in Canada, compared to open prostatectomy that still had a risk of retreatment but was much lower. So the Austrians decided to check that if that was a problem of the other countries or if also was present in Austria. And they checked between 92 and 96. And they arrived to a similar conclusion. At 80 years, the rate of retreatment after TURP was almost 80%, so 1% per year increase. Any endoscopy at 8 years to correct something that was wrong, almost 15%. And even after open prostatectomy, there was a necessity of repeating surgeries, including repeating the prostatectomy. Well, they thought to review that a few years later. And so Austria again between 22 and 26. And it did not change. So it looks like that we have a ceiling effect. There is a maximal possibility for our surgeries, and after that we cannot do better for TURP and for open prostatectomy. So we should inform our patients that we don't do miracles. We do surgeries and they might not work well in all patients. By the way, this is the French data, and again, at 5 years, you see the rate of de novo TURP de novo, which is higher than the open prostatectomy, and much of course, the other techniques, including incision of the prostate, the risk of de novo surgery is, of course, much higher. Well, then you see that the laser vaporization received a strong indication from EU guidelines, and an example is the Goliath study, which showed that at 12 months, compared against TURP, IPSS, Qmax, PVR, PSA decrease was exactly the same. So we might say, okay, so we can offer these to the patients because the results are the same. But this is at 1 year of follow-up. Just look the difference in the rate of retreatment for all laser phototherapies or vaporizations in the long term. There is, in fact, a risk of retreatment after photoselective vaporization that is higher than after TURP. Why? We don't know. And this is just food for thought. But one thing that we might induce in the prostate with these surgeries is chronic inflammation. And chronic inflammation releases interleukins. Interleukins tend to increase the activity of the androgen receptor and tend to increase the activity of transforming growth factors. And that might lead to cell proliferation. And in fact, on the right side, you see a disilvary correlation between the prostate volume and the chronic inflammation. The blue line indicates a strict correlation between the intensity of the chronic inflammation and the prostate volume. So eventually, if we induce chronic inflammation after surgery, we might promote cell proliferation in the long term after the surgery. And what about Urolift? Well, the first study comparing TURP with Urolift at 1 year showed that, well, the results were very similar in terms of IPSS, and the quality of sexual life was superior after Urolift. But that is 1 year after the placement of Urolift. Just look at this BPH6 study. Again, Urolift against TURP. The prostates are well indicated, small prostates, low PVR, no middle lobe, 2 years of follow-up, and the improvement of IPSS and Qmax is superior for TURP. Of course, ejaculation is preserved in the Urolift, but 14% of retreatments in the Urolift. By the way, in this group, at 2 years, the retreatment rate was TURP. So probably the guys that were doing TURP were not, I think they need to practice a little bit more. Let's say that 2% a year is probably too high. You agree with me? And what about the new techniques? The rhythm system. At 3 years, the improvement is no better than MTOPS. The improvement in flow is no better than 3.5 mLs per second. The retreatment rate is high, and there is also the risk of acute urinary retention. So we don't have data, long-term data. If we go to aquablation, again, very quickly in 1 year, aquablation looks very similar to TURP. But if you look to the retreatment rates at 1 year, you see already a difference between TURP, 1.5%, which is the average, and 2.6% after aquablation. And if we talk about embolization of the prostate, well, we have to be careful, very careful, because the follow-up is short and because the decrease in the prostate volume is relatively low. And so that might indicate that in the future, the need of retreatment might be very high. So to conclude, Patients might be unhappy for many things, including the cost of the surgery. The bill might be very high. But they might be unhappy because there is a persistence of storage or voiding symptoms, because they were not well evaluated at the baseline and the symptoms were not those that should be indicated for TURP, because they develop underactive detrusor, or because the surgeon did not master or the surgery. There are limits for TURP and for open prostatectomy, and it seems like that we cannot overcome those limits. Photovaporization also has limits. It might be a nice surgery with less complications at the very beginning, but might cause chronic inflammation. And we have to be very careful about the use of those new techniques without long-term efficacy demonstrated. Thank you very much.
Teşekkür ediyoruz Sayın Cruz'a. Zamanı iyi kullanmak adına bir iki soru alabiliriz. Buyurun hocam.
Bu septomatolojide açık prostatektomi ile TURP arasında membranöz üretra darlığıyla mesane boynu darlığına bağlı olanlar açık prostatektomide mi avantajlı yoksa TURP'de? Yani TURP daha çok mu membranöz üretra ve mesane boynu striküne neden oluyor?
My opinion is that the two surgeries should be indicated in different conditions, and that depends on the prostate size. Well, if we are talking about bladder neck contractions, certainly the incision of the prostate might be a good option. If we are talking about small prostates, and if you master the technique, you can go until 80 mL without problem. Probably I might go a little bit further. Probably Erwin will go to 100 without problems. I don't know. It depends on how quickly you resect the tissue. If you are not able to resect the tissue within 1 hour, then it's better to do an open prostatectomy, because in the end, it's better to do one surgery that will provide a good quality of life and a good long-term effect to the patient than to offer, let's say, a half TURP and to be sure that the patient will come back to you within a few years.
Son soruyu Tufan hocamdan alayım.
Francisco, gerçekten çok güzel bir sunumdu. Çok teşekkür ediyoruz. Ben kendi adıma çok faydalandım. Bahsettiğiniz gibi Paul Abrams'ın merkezinden çıkan transüretral rezeksiyon, prostat ameliyatlarını belki sorgulayamayız ama ben kendi pratiğimden düşündüğüm zaman en çok TURP sonrası problemlerin sebebinin yetersiz TURP olduğunu, yanlış cerrahi teknik olduğunu görüyorum. Yani pratik yaşam belki biraz daha çalışmalardan farklı olabilir. Mutlaka karşımıza bizim atlanmış dektisör kasılma problemleriyle ilgili hastalar da geliyor. Ama benim pratiğimde en çok ameliyat sonrası problemler o ilk ameliyatın yanlış tekniğiyle ilgili. Bunu paylaşmak istedim. Bilmiyorum nasıl Portekiz'de durum.
Well, I might agree with you that with TURP you remove less tissue, and if the technique is not the ideal, if the urologist has, let's say, a less than optimal training, the tissue that will be removed will be just a small amount, and probably the prostate cavity will not be smooth and that will cause some changes in the urine flow. So that is a problem. But also for those that do not master TURP, probably they do not recognize that some symptoms will not improve with TURP. Don't offer TURP to treat urgency. Don't offer TURP to treat frequency unless you have a high PVR. Don't offer TURP for the treatment of nocturia unless you have a large PVR. So patient selection is extremely important. If you don't master the technique, don't offer TURP for a prostate of 80 mL. Offer until 40 mL, and so you are confident, and with time you will probably arrive to the 80 mL.